Hi, ladies and gentlemen. It's my pleasure to give a lecture on new ways of non-invasive intra-abdominal pressure measurement at the virtual ISICEM symposium. These are my conflicts of interest and my biggest bias being the co-founder of the Abdominal Compartment Society. This happened in 2004 in beautiful Noosa. Although the weather was not as good, it was raining cats and dogs, and we were fortunate to have Fox Creek Wines as a sponsor during the wine breaks. I have a huge bias, and this is a picture given by my trainees. Whenever I ask a question, the answer is intra-abdominal pressure. I'm very fortunate to have met the Queen and the King of Belgium personally, as well as the Minister of Health. This will be the overview of my talk. Impossible task in 12 minutes, but let's start. Everything I will tell during my presentation can be read in this foam free open access paper, and I thank Salar and Johan for working on this, and we will continue some research. What are the determinants of intra-abdominal pressure and volume? If we consider the abdominal cavity to be primarily fluid in character, the pressure should be equal, but of course there may be other forces like gravity, the uniformity of compression, shear stress, and contractions of the abdominal muscle that may play a role. So you can measure abdominal pressure via the bladder, via the stomach, direct, intraperitoneally, and also rectal pressures have been described. So the direct pressures are not to be used in intensive care, and the indirect pressures like bladder and stomach can be used in critically ill patients. Bladder pressure is still the gold standard, but the problem is you cannot measure continuously, because if you drain the urine, the pressure will drop. You could use a three-way Foley catheter, but this is cumbersome and not well validated. We looked about the possibility to use the Foley's own balloon to transmit the pressure in a bench model, and we found quite good relation between pressures of 0 and going up to 100 centimeters of water. Nowadays, there is a device commercially available, the Acrorin, that measures urine output and abdominal pressure continuously, and I'm medical advisor for Sereno, an Israeli startup, and we did a first in human looking at continuous urine output, and we will soon validate also continuous intra-abdominal pressure. So non-invasive ways, anthropometry, which is a scientific study of the human body measurements and proportions, may give us some clues. If you look at the Venus on the left, the waist to hip ratio is below 1, and the Venus of Willendorf has a very high waist to hip ratio. So the Venus on the left may have a much better abdominal compliance, which means that for the same volume, the pressure will be lower. Hence, there are some clinical clues that you can assess in your patients, like obesity, will decrease compliance and increase intra-abdominal pressure. So we performed a study in about 100 patients looking at different anthropometry measures. And what came out is that umbilical diameter, ribcage circumference, waist circumference, and the abdominal perimeter were higher in patients with abdominal hypertension. This is a statue of Manu Malbrain. It's a statue in the city of Leuven where all the students are, and she was quite damaged, so she moved her to the waterfront, and sometimes she gets flooded. Which brings me to some other anthropometry measurements, which is the sagittal abdominal diameter and the ribcage height, which were also found to be higher in patients with abdominal hypertension. And then the last measurement is the connection between the xiphoid and the symphysis, when you have the straight line and the curved line, and when you have the difference between the two. So the latter were also significantly higher in abdominal hypertension. So this is clinical examination. What about tensiometry? Tensiometry is applying a force on a surface that creates a certain indent. So you cannot assess abdominal pressure by putting one hand or two hands on the abdomen, unless you're a surgeon, because they claim to be able to assess abdominal pressure just with clinical examination, nor using a perimeter. Why isn't it good? Because sensitivity and specificity is quite low. So you could use this kind of tensiometer where you apply a force, and this is the indent is related to abdominal pressure. So the stress in the abdominal wall is related to the pressure inside, outside, the radius of the surface that applies the force and the abdominal wall thickness, and then you could calculate intra-abdominal pressure. This has been validated by Van Ramhorst in study of dead corpses and found a reasonable correlation between the tension and intra-abdominal pressure, and recently has been validated also in ICU patients. Next, let's talk about respiratory impedance or inductance plethysmography, which is measuring ventilation by looking at the movement of the rib cage, RC, and the abdomen, AB, and you have an elastic coil, and this changes with movements, and you can have an idea of relative changes in ribcage volume and abdominal volume. So with these formulas, if you have a tidal volume excursions, this will also result in intra-abdominal volume excursions, where alpha and beta are correlation coefficients between motion and volume changes, and delta L are the dimensional changes. So you could estimate intra-abdominal volume. What about strain gauge? Well, a strain gauge is a device whose electrical resistance varies in proportion to the amount of pressure force applied. So this has been used in thoracic surgery, in dorsal vertebra surgery, where they increase the pressure and you see the effect on muscle tension. And as you can see, there is a good correlation. Point of care ultrasound is something that everyone uses in the ICU. So the next non-invasive method is ultrasound with the use of external pressure. So you could imagine a bottle where the height in water is the pressure exerted on the abdominal wall. And if you remove the bottle and you see that the abdominal wall is going up, this could be then that the pressure outside is quite similar to the pressure inside. It's quite cumbersome. Another method is using ultrasound with a vein press, and you can appreciate if the pressure in the abdomen will be higher, then this interchamber distance will be smaller, and this is related to intra-abdominal pressure. Looking at the abdomen, it's usually oval or ellipse shaped. If you increase the volume, there is a reshaping phase, a stretching phase, and then a pressurization phase. And you may notice that the abdominal wall thickness will become smaller if the pressure increases. So by looking at the abdominal wall thickness with ultrasound at different points, P1 to P6, you can see here at P3 and P6 in two patients, you can see that there is an inverse relation between intra-abdominal pressure and abdominal wall thickness. Another method is ultrasound by use of tonometry, again with a vein press device. So if you apply an external force of 40 millimeters of mercury, you will see that the diameter in the compartment may be smaller. And this refers to the elasticity ratio. And again, intercompartment pressures were related to this elasticity ratio. Another technique is Doppler ultrasound. We know very well in the ICU, we have a piezoelectric transmitter and we assess blood flow. And if we apply a force, this may result in a distortion of the Doppler signal. Hence, we found a relation between intra-abdominal pressure and velocities in inferior vena cava and right femoral vein. Ultrasound can be done also with laser. I'm not going to explain you the principle, but with laser, we're able to listen to ultrasound, and when the pressure increases, the waveforms are distorted, changing the decibels, and you could have an idea of pressures as well. Bioelectrical impedance, which measures the amount of opposition that a certain tissue has in preventing electrical current from passing through. Again, looking at the abdominal wall, if you have a lot of water fluid overload, then impedance will be low. And the study found a good correlation up to pressures of 7 between the absolute impedance and intra-abdominal pressure, but they were not able to discriminate at higher pressures. Digital image correlation is tracking an image and registering it and measuring the deformation with different cameras on a tensile specimen. You can imagine A is normal abdomen and B is with insufflation during laparoscopy. So you change the 3D, and by tracking this, you can form. Wireless is the future, and this is a wireless capsule to measure gastric pH, but it also has a pressure sensor, so it would allow to measure intra-abdominal pressure continuously. And finally, the microwave reflection, and this is a study by Marcelo David in pigs, insufflation, where you have the microwaves emitting and sensing, and by changing the intra-abdominal pressure and emitting the waves at different frequency. You can see that the scattering parameter S11 is a function of intra-abdominal pressure, and now they were able to discriminate up to pressures of 16 millimeters of mercury. So one more thing, the future is continuous because we need trends, we need perfusion pressure, automatic interactions between compartments, look at the impact of ventilation, recruitment, and compliance. One last more thing is that automation is also important. If you look at an abdominal pressure tracing, you can easily identify the intra-abdominal pressure, respiratory tracing, you can look at inspiratory and expiratory abdominal pressure, but you can also identify a pulse pressure tracing, and just assessing non-invasively abdominal pressure, you can have an idea of heart rate as well as pulse pressure variation. Isn't that very interesting? So I think continuous is the future, and also these extra parameters that you can get from a raw abdominal pressure tracing. So one very last more thing. I showed you all the different non-invasive devices, and they are in the infant stage, but they are very promising for the future. And when we align all these different techniques and score them, whether they take a lot of time, whether they're easy, whether there is interference with ICU equipment, we come to the conclusion that bioelectrical impedance and microwave reflection may be the best choices for the future. So ladies and gentlemen, to wrap things up, I think that there are non-invasive ways to measure abdominal pressure. Continuous measurement is the future. It has a tremendous impact on the way we look at the patient and we treat the patient with respect to organ function monitoring, interaction, and treatment. So if you want to learn more, I can advise you this book on intra-abdominal pressure, published by Cambridge University Press, and there will be a new book coming out later this year. So I would like you to go home with the knowledge that clinical estimation of abdominal pressure is unreliable. Measuring abdominal pressure is knowing hypertension. Use the technique that your nurses will use. And there are non-invasive techniques that sound very promising. Bioelectrical impedance, either or not in combination with microwave reflection and or in combination with point-of-care ultrasound, Doppler, and respiratory inductance plethysmography. Continuous abdominal pressure has major advantages and an enormous impact on bedside clinical management. Having said that, I kindly invite you to the virtual Fluid Academy days. Thank you.